Okay. Okay, thank you. Thank you for the opportunity. So, I mean, I guess this is not an easy topic to actually talk on, considering that there is so much which we've learned over the past year about the immunology and the pathogenesis of COVID-19. So it's a complex topic, but I'll try and see what I can do to actually distill it into a sort of in a manner that is understandable by most people here. So the outline of my talk, I'm just going to talk a little bit about the virus itself, then immune responses to the virus, then immunopathogenesis of COVID-19, and finally, I'll end with immunopathogenesis of MIS-C. As we all recognize, MIS-C is probably the most important thing when it comes to children. The virus, I mean, as we all know, it's a coronavirus. The coronavirus, there are many coronaviruses which cause human disease, of which the coronaviruses which cause disease, the SARS-CoV, the original SARS-CoV, which happened in 2002, 2003, then the MERS-CoV, which happened sometime in 2013, the Middle Eastern Respiratory Syndrome virus, and the SARS-CoV-2, they all belong to the beta coronavirus, virus 2. Alpha and Delta coronaviruses, of which all the really pathogenic coronaviruses belong to this beta coronavirus group. And there are a few other coronaviruses which can cause human disease, but they all cause milder human disease. Now, out of these, the SARS-CoV-2, even though the closest virus to the SARS-CoV-2 is actually the bat coronavirus, the rat G13 coronavirus, which actually has about 96% similarity to the SARS-CoV-2, the one which has got pathogenesis which is similar to SARS-CoV-2 is the SARS-CoV virus, which has only about 80% similarity to the SARS-CoV-2 virus. Now, we all recognize that the coronavirus is a sort of like a spherical virus. It's got a lipid bilayer onto which there are these structural proteins, of which the most important proteins are the spike protein, then you have the membrane protein and the envelope protein. And the spike protein itself is the one which is responsible for attaching to the human cell and entering the human cell. You have another structural protein, which is the nucleocapsid protein. The nucleocapsid protein actually gives sort of a backbone to the RNA. It's a single-stranded RNA virus. The spike protein, there are two components to it, the S1 and the S2 component. The S1 component is the outer component which attaches to the host cell, and the receptor binding protein, which is actually present in the S1, and it's the S2 protein, which is the stalk which attaches the S to the lipid bilayer of the SARS coronavirus. Now, if you look at the life cycle of the virus itself, the virus actually uses the ACE2, the angiotensin converting enzyme 2, as its receptor for binding onto the host cell. And it uses another protein, which is the transmembrane serine protease, which is important for fusion of the virus to the host cell. So, and there is endocytosis which happens, and the viral genome gets incorporated into the cell, and then your translation of the single-stranded RNA, there is RNA replication, and finally there is transcription, and the membrane protein, the envelope, and the accessory proteins are produced in the Golgi apparatus, and the viral assembly happens. within the cell, and the virus matures, and then the virus is released, and that forms the life cycle of the virus. Now, the important parts to this are, I told you there is this transmembrane serine protease which is there, and it is also a target for a particular drug called carmostat, which is a serine protease inhibitor. So it is one of those areas where it can actually work to prevent entry of the cell into the host cell. We all are well aware of the antiviral drug remdesivir, and remdesivir itself actually is it's a inhibitor of the RNA-dependent RNA polymerase. It's a mimic of adenosine triphosphate, and that is how it actually works as an antiviral agent, and it works at this stage where RNA replication happens. Now, the ACE2 expression is one of the important features which actually gives tells us where all the virus can be and what all the virus can cause pathology. Now, different tissues in the body actually express these ACE2 enzymes at different levels, and if the expression of the ACE2 enzyme is high, that organ is likely to be infected more. So what are these areas where the ACE2 expression is high? So more than 1% is in the lower respiratory tract, the lung, the heart, ileum, esophagus, kidney, bladder, and very little expression happens in the stomach and the liver. That also goes to show why liver is not actually very much affected with SARS-CoV-2. You must also remember that the endothelial cells also have a significant amount of ACE2 expression, because of which there is endothelial cell damage causing pathology when it comes to infection with SARS-CoV-2. Also, there is among children, there is lower expression of ACE2 in both the nasal and the bronchial epithelium. So because of this, the virus itself actually doesn't get bound to this thing as much as it would with the adults, and probably that might explain some of the reasons why it is a milder illness in children. And we all recognize that comorbidities such as diabetes, obesity are all associated with increased disease severity. And one of the reasons could be this ACE expression, which is actually increased with these comorbidities. Now, I mentioned about the multiple proteins which are there in the SARS-CoV-2 virus. Now, antibodies to this are also produced, and the most important antibodies are the anti-spike antibody and the anti-nucleocapsid antibody. There are IgG, IgM, and IgA antibodies produced. Now, you must remember most of the vaccines are actually against the spike protein. So it produces spike antibodies. So if you have somebody whose antibody is positive for the spike protein, you can imagine that it's not necessarily because of an infection, and it could very well be because of vaccination. Similarly, if the anti-nucleocapsid antibody is positive, it could very well it's not because of a vaccine which is among the vaccines that we have. We have Covishield and Covaxin, and Covaxin, we all know that it's a whole cell vaccine. So the number of antibodies which are produced against the Covaxin, it's a little more wider than what is there in Covishield, because Covishield only produces anti-spike antibodies, whereas with Covaxin, you can also have anti-nucleocapsid antibodies. So if you have anti-nucleocapsid antibodies, it could mean that you've either been vaccinated with Covaxin, or if you've not been vaccinated or vaccinated just with Covishield, it could mean that you've already had the infection as well. Now, another important thing to remember, after the SARS-CoV-2 exposure, the virus actually replicates, and it replicates and becomes transmissible even before the onset of symptoms. So here in this graph, it's actually day 0 is symptom onset, but the RNA levels are much higher. In fact, it sort of peaks around the time the symptom onset happens, which also means that transmission happens around, transmission is actually highest at the time symptoms starts, and it even happens before the onset of symptoms. And then you have the antibody response, IgM, which goes up and then it falls within a few weeks. And the IgG response actually lasts for, it could last for many months. We don't know whether it will last for years. We don't know, but we do know that it actually lasts for a fairly long period, and how much, whether this antibody response, how useful it is in preventing severe disease, we don't know all those information for sure. When you think about COVID natural history, it's important to recognize COVID in these three phases. Dr. Srinivasan mentioned, we sort of know the pathophysiology of dengue, which is why dengue is actually a fairly easily manageable disease right now. Similarly, if we understand that COVID also has a certain pattern to its course, we can actually intervene at these different stages with the specific intervention strategies. So what is the three stages are: stage 1, which usually happens in the first 5 days. That is stage of early infection. Now, that is when viral replication is maximum. During this period, the patient could be asymptomatic, or they can have mild or moderate symptoms. And the PCR is often positive because the viral loads are higher. Now, if you really want to give an antiviral, this is probably the time to give it. Next comes the stage 2, which is actually the pulmonary phase. Now, replication of the virus slows down, but the lungs get infected. There is pneumonia. The patient is getting sicker. They might have dyspnea. Chest X-ray might show opacities. The CT scan may show ground glass opacities. Now, around this time is also the time when the host cell inflammatory response increases. Now, after this, about 10 days, I mean, the first phase is about 5 days, the second phase for another 5 days. So after the 10 days, the virus replication has stopped. But this time is when the patients become, if they were to become sick, they really become sick because of the hyperinflammation that happens during this phase. This hyperinflammatory response leads to pneumonia. It affects multiple systems. It can cause a sepsis-like picture. There is respiratory failure. There is features like ARDS. All this because of the cytokine storm. So this is something, I mean, if there is nothing that you get out of this particular session, I think this is probably the most important thing, that you sort of recognize COVID in these 3 stages: the early infection stage for 5 days, the pulmonary phase for the next 5 days, and after 10 days, you have the hyperinflammatory phase. Now, if you look at any, the immune response to any pathogen, what we've shown here is a SARS-CoV-2 infection. First thing that happens is the innate response. And this innate response is often with dendritic cells, which take up the antigens of the SARS-CoV-2 and present it to the other cells. And you have induction of adaptive immunity, which comes into play after that. And you have T helper cells, T regulator cells, you have cytotoxic T lymphocytes, and T follicular helper cells, which help in the induction of antibodies. Now, after this, you have a period where there is recovery to SARS-CoV-2, and there is immune memory. And this immune memory can be T cell mediated as well as B cell mediated. So there is antibodies as well as T cell mediated immunity, which actually can stay on for many months or even years. Now, what happens with COVID-19? Now, there are 4 important things which happen. First is the depletion and the exhaustion of lymphocytes. Next is the increase in the number of neutrophils. Next, there is an increased production of cytokines. And finally, it is possible there is some amount of antibody-dependent enhancement, which could lead to the pathogenesis of COVID-19. Now, when I say depletion and exhaustion of lymphocytes, that the lymphopenia is actually a marker of severity in COVID-19. So if you have very low lymphocyte count, that actually correlates well with disease severity. Now, why does this happen? the spike protein, which, I mean, the ACE enzyme, which is actually the receptor for the SARS-CoV-2, is also present in T cells. And this itself can actually cause the coronavirus to actually directly infect the T cells. And this causes impairment of the T cells and then cause decrease in the lymphocyte number. Then you have T cells which have an increased sensitivity to TNF alpha, interleukin 6, and interleukin 10, which actually are produced by macrophages and lymphocytes, and that actually causes T cell depletion and exhaustion, which again causes lymphopenia. And also the virus directly infects the spleen and the lymph nodes. You can have, I mean, in pathological studies, they found that there is actually necrosis of the lymph nodes with COVID, and this again can cause lymphopenia. And finally, there is some amount of lactic acidosis which is produced, which actually causes T cell impairment as well as dysfunction. So the first thing that happens is the decrease in the lymphocyte number as well as the function. Next, there is an increase in neutrophils. Now, this increase in neutrophils is likely because of lymphopenia and associated microbial infection. And there is this microbial infection causes activation and recruitment of neutrophils to the site of infection, causing an increase in the number of neutrophils. And thirdly, which is what happens during the third phase, that the hyperimmune phase, is this cytokine storm. Now, this cytokine storm, one, it could be because of the activation of monocytes, which is with the help of T helper cells, and there is a Th1 response, and there is increased GM-CSF, and the CD14 positive and CD16 positive monocytes produce a lot of IL-6. Now, mind you, I mean, tocilizumab, the drug which is used for acute COVID, is an IL-6 inhibitor. So it's probably one of the ways in which actually that works. Then, secondly, you also have monocytes, which are CD14 positive monocytes, which are activated, and they produce a lot of interleukin 1 beta, which again takes part in the cytokine storm. Then there is the Th17 response, which causes increase in IL-17, which recruits many monocytes, neutrophils, and macrophages, which again increases the amount of IL-1, IL-6, etc., which leads on to this cytokine storm. So finally, you have many cytokines which are unregulated, and when they are unregulated is when they contribute to that hyperimmune phase. So we must remember that it is during that phase, the key answer to the problem is actually decreasing the cytokine storm at that point. And finally, the concept of antibody-dependent enhancement. We all understand antibody-dependent enhancement in dengue, where you have the first infection with a particular dengue virus, and if you have a heterologous viral infection subsequently, there is only partial immunity, and this partial immunity actually enhances the entry of the dengue virus into the host cell, and it increases the pathogenicity of the virus. Now, there is this theory proposed that if you have partial immunity to coronavirus, when the infection happens, there is an increased propensity of entry of the virus into the host cell, causing increased pathogenicity, leading to poor outcome and increased disease progression. Now, it's a good theoretical possibility, but we've not seen this play out as such, because we all recognize that, if this were true, then people who've been infected in the past are likely to have actually more severe disease, especially if they are removed from their first infection. Also, if you're vaccinated, it is possible that you can have more severe disease also. And all these things have not played out like this. So I'm not quite sure whether this forms a significant part in the pathogenesis of COVID-19. this is an important concept to remember. That is, the immunity which happens to COVID-19 could be protective, which means it is lytic to the SARS-CoV-2, which clears the SARS-CoV-2, or the immunity just could go out of hand, and that immunity going out of hand actually leads to the bad cytokine storm, which actually contributes to the increased pathogenesis of the severe disease. So once you have the native T cell, which is activated, it goes into the lymph node, and on one side you have the CD4 cell proliferation, which leads to memory T cells, and also which leads to plasma B cells being activated, and there is production of neutralizing antibodies, and there are cytotoxic T cells which again produce certain cytokines which actually result in SARS-CoV-2 clearance. Now, this is what happens when somebody has mild to moderate disease. But if somebody were to have severe disease, this T cell proliferation, actually there is a down regulation of effector T cells, but there is an up regulation of monocytes as well as neutrophils. And this leads to this cytokine storm, and with the production of these particular cytokines, such as interleukin 1 beta, TNF alpha, interleukin 6, and many other cytokines, which actually it forms one vicious cycle where there is more and more cytokine production, and this hyperinflammation actually causes the pathogenesis, the pathological effects of severe COVID disease. Now, there is also direct infection of the vessel walls, causing endothelial damage, and this can lead to thrombosis. There is also hemophagocytosis and reduction in hematopoiesis, which all contribute to the bad effects of SARS-CoV-2, I mean, those who actually develop severe SARS-CoV-2 infection. For some good reason, this one, which is actually shown in the pink, doesn't happen so often in children, and it's often what happens in blue, which happens in children. And this, what shown in pink, is often what happens in adults with comorbidities. So why do children have it easier than adults? So these are proposed theories. One we know for sure is that there is actually decreased ACE2 receptor and the transmembrane serine protease expression in the respiratory epithelium of type 2 alveolar cells in children, and it increases with age. So there is just not enough receptors for the SARS-CoV-2 virus to actually attack the alveolar cells. Also, a bulk of the problem is because of the adaptive response, which is overactive. Now, children have strong innate responses, but they have poor adaptive responses. And there can be other respiratory tract viruses which inhabit the respiratory tract of children, and so they compete with SARS-CoV-2. So SARS-CoV-2 has lesser area to actually fight with the child's respiratory tract. Also, there are lesser TLR-induced responses and increased T regulatory cells in pediatric lungs, which actually suppress immune response, which prevent a cytokine storm. There is also less lymphocytopenia. I told you lymphocytopenia is correlated with severity. There is less lymphocytopenia among children. And microvascular maturation and alveolar genesis, actually it's a continuous process in children, whereas in adults it's already happened, and when there is damage, there is no provision for repair. And the pulmonary endothelial barrier is actually well preserved in children compared to adults. So these are some of the reasons why children have it easier than adults. Now, finally, a little bit about immunopathogenesis of MIS-C. MIS-C, as you all know, it's multi-system inflammatory syndrome, which happens in children, and it's temporarily associated with the SARS-CoV-2 infection. This is a delayed immunological phenomenon which is associated with inflammation. It follows symptomatic or asymptomatic COVID-19 infection, and it is usually about 1 to 6 weeks after the infection. Now, it's often negative. It often associated with negative PCR and positive antibodies. You can imagine if it happens 1 to 6 weeks, if it happens in the second week after infection, PCR may be positive, but anything after that, it's often only the antibodies which will be positive. So, I mean, this looks like a complicated slide because it is a complicated event which happens. So, I told you that there are these three phases after a COVID-19 infection. One is the stage of the early infection. Then you have the stage of the pulmonary phase where it's mainly the lungs which are involved. And finally, the hyperimmune phase. Now, for some reason, children who have mild infection, either asymptomatic or symptomatic infection, skip this pulmonary phase and go directly into this hyperimmune phase, but in a delayed manner. This hyperimmune phase actually happens a little later than acute SARS-CoV-2 infection. Now, there is macrophage activation, which activates helper T cells, which produces again activates the B cells and plasma cells, leading to a lot of antibodies. And there is also production of this increased amount of cytokines, including TNF beta, IL-12, IL-6, IL-1 beta, IL-23, IL-4, interferon gamma. So there's a whole load of cytokines which are released, which again stimulates macrophages, neutrophils, and monocytes. And this vicious cycle happens, and there is a hyperimmune response. And this causes changes in the many tissues in the body, which can include meningeal irritation. There is pulmonary edema, consolidation, and atelectasis. There are skin changes, there is acute kidney injury, there is coronary aneurysms, shock, and involvement of the abdomen with ileitis, colitis. Now, all of these can happen. Now, there is also a small component which may predispose certain children to actually develop all this. So there may be a genetic predisposition to this happening among children. Now, this is a very recent paper which was published maybe in the last couple of weeks, which have shown that there are monogenic variations, which actually, if these monogenic variations are there is increased inflammation, which leads on to MIS-C. And if these variations are not there, with these genetic risk factors are not there, they usually present with just either mild or asymptomatic disease. So there may be a genetic component to MIS-C. Now, MIS-C, even the hyperimmune phase of...
Dr. Winsley, another 2 minutes, please.
Yeah, should finish in very quickly. MIS-C, actually, it's the hyperinflation in MIS-C and Kawasaki disease. There is a lot of hyperinflation in both cases. That actually differs from severe acute COVID-19. How does it differ? With acute COVID-19, there is IL-8 which is produced, which is associated with lymphopenia, and also increased IL-7 production, which actually causes, which is a T cell maintenance cytokine, which is increased. Whereas that is not so in MIS-C and Kawasaki disease. Similarly, immune response, even though MIS-C and Kawasaki disease actually seem similar, the immune responses between MIS-C and KD are also different. Now, this is just a violin graph you can actually look at the graph and make out that there is actually difference in the T cell responses with MIS-C as well as Kawasaki disease, whether it be memory T cells, effector memory T cells, or naive CD4 T cells. So even though they look similar, there is difference in T cell mediated responses with MIS-C and Kawasaki disease. Also, not only is it T cells, it's also cytokine responses. So the cytokines which are produced among MIS-C and Kawasaki disease are also different, which is shown with this violin graphs. There is higher IL-6, IL-17A, CXCL10 in Kawasaki disease. And particularly, there is a cytokine called DCBLD2, which is higher in KD, which is associated with balloon coronaries. We are all aware that KD actually causes more coronary involvement than MIS-C, whereas MIS-C causes more myocardial involvement. Serological responses in MIS-C, it's similar in SARS-CoV-2 and MIS-C patients. There are really no difference in the serological responses between these two. But pre-existing immunity to other coronaviruses are lower in MIS-C compared to those with MIS-C, without MIS-C. And there are many autoantibodies found in MIS-C, which are, however, different from those found in Kawasaki disease. And these elevated autoantibodies related to arterial damage are more in KD compared to MIS-C. Now, finally, about treatment. IVIG is useful both in MIS-C and KD because it can actually neutralize many of these autoantibodies. Similarly, corticosteroids, it causes a more general immunosuppression, but the precise role in MIS-C is unclear. And we all recognize that use of anakinra, which is a IL-1 receptor antagonist, actually neutralizes strong IL-1 responses elicited by endothelial damage due to antibodies as well as complements. Now, TNF-alpha blockade is useful in acute COVID, but not useful in MIS-C because TNF-alpha is not produced much in MIS-C. Similarly, IL-6 blockade, I mean, we all are used to using tocilizumab, which is actually a good drug for acute COVID, but not MIS-C because, again, IL-6 levels are often normal in MIS-C. So finally, to conclude, immunopathogenesis of COVID-19 infection and MIS-C is still far from being fully understood. It's this thing in evolution, and it's useful to consider the pathogenesis of COVID-19 in 3 phases: early infection, pulmonary phase, and the hyperinflammatory phase. There is lymphopenia, increased neutrophils, and increased cytokine response, which are hallmark of COVID-19 infection. Now, MIS-C, the immunopathogenesis is different from acute COVID and also different from KD, but it is closer to Kawasaki disease than to acute COVID-19. With this, I'll conclude. Thank you for this opportunity.